So we are moving from looking at the hematocrit control alone to controlling the white cells, platelet symptoms, and the spleen. And Rami, in your hands, then, if those factors are not controlled well, and certainly you would like to primarily have control of hematocrit, and then the white cells and the spleen and the symptoms and the platelets, perhaps then there would be, I would certainly think, a number of cases where you are unable to control the 5 factors that I mentioned with hydroxyurea alone. Therefore, there is a room for more therapies, and the targeted therapy that we are talking here about is Ruxolitinib. It seems that it's very valuable in a second-line setting. We have 60% normalization of the hematocrit. We have about 25% of patients controlling all blood cell count, and it's very durable. I think durability particularly is impressive to me. What's your take on utility of Ruxolitinib in a second-line setting?
No, I totally agree. I absolutely agree. I think, obviously, as Andrew mentioned, we are looking at different dimensions. We are looking at a long-term disease outcome, short-term outcome. Most of those patients have good prognosis, but we're looking at is the thrombotic events as well as the symptoms. And we typically don't think of P. Vera that patients are symptomatic, but when you start talking to patients and listening, many of them had like itching that sometimes can interfere with activities, fatigue. Some of them will have symptoms from the spleen, vasomotor symptoms. So I think, like Hydrea sometimes will not do as great job controlling those aspects, even if the hematocrit is better controlled. The other thing I always talk about is like basically when we think about phlebotomies and what is acceptable and how often should we do phlebotomies on those patients. Is it really acceptable that we are doing a phlebotomy every month on those patients? And although there may not be evidence that, phlebotomy per se is harmful, but I think a patient that is requiring on, regular basis phlebotomies have inadequate disease control or a disease that's really active, that we may need to think of changing therapy based on that. The other thing, it also depends how often do you look. So if, we are seeing those patients and we are just checking hematocrit every 4 months, sometimes in between, we don't know how long they are staying above that target of 45 that we aim for. So maybe sometimes also looking more often. I think Ruxolitinib offers a great option of controlling disease for patients that is sometimes difficult to control with Hydrea, especially when you start going on the higher doses. In my experience, toxicity with Hydrea starts to become very prominent when the dose is more than 2 grams per day. Patients will have nausea, sometimes sores. You start seeing more myelosuppression with the treatment. So if patients have symptoms, especially on a higher dose, if they are still requiring phlebotomies, if I'm not able to maintain their hematocrit in that range below 45 on regular basis, for those particularly that have drenching night sweats, fevers, itching, I find Ruxolitinib as a very useful option for patients. And also interferon, sorry?
Let me ask Andrew one more question about the other side of the coin. We briefly said about herpetic infections and squamous cell carcinoma of the skin. Is there a main concern here, or we are able to control those by perhaps monitoring patient skin and providing perhaps advice on the management of herpetic infections?
So yeah, I think that there's, these are the main side effects that we talk to patients about that I think are concerning, certainly the shingles reactivations and the non-melanoma skin cancers. Recently there was a presentation that suggested that the patients that were at a higher risk for these non-melanoma skin cancers were patients that had previous non-melanoma skin cancers. And I think that helps to certainly identify patients that are at higher risk. And often those patients already have dermatologists, and we can counsel them to see their dermatologists more frequently to be able to prevent these things from occurring. As far as the herpetic and shingles infections, we're not really sure how the new shingles vaccine impacts that. But certainly it's something that's recommended from our standpoint, as it's not a live virus vaccine, and it has shown efficacy that's preferable to the prior shingles vaccine. But I think that what I counsel patients on is, this is oftentimes this is a group of patients 65 and older that are at risk for shingles reactivations already. And shingles reactivations can be something that, when managed early in the course of the disease, can some of the problematic symptoms can be mitigated. Sometimes the trouble is not recognizing this, and so if counseling patients, they can become more aware of this and hopefully present to medical care earlier on in the disease process.
And so we balance here with the occasional side effects that you mentioned by carefully monitoring patients, but we count on a tremendous improvement, not only in blood cell count, but quality of life with ruxolitinib, and perhaps even improvement in the iron levels, eliminating that possible side effects of otherwise problematic issue in some of the patients. So I thank you all very much for this lovely discussion. We're going to conclude this case and move on to the next one. Thank you all.